introduction to prescribing medication to end life. We are fortunate to have with us tonight representatives of the groups that are proponents of the proposed law, as well as the major group that's in opposition to the proposed law. The proponent tonight is Kevin Cousin, who's a licensed social worker and a clinical social worker and therapist who specializes in relationship issues dealing with chronic pain, illness, loss, and grief. He currently works at BU School of Social Work and has been a longtime member of the National Association of Social Workers, and is currently on the board of directors of that organization. And he's representing Dignity 2012. Vote yes on this ballot initiative. Welcome, Kevin. Thank you very much for coming. And speaking in opposition tonight, Patricia Stewart is a native of North Attleboro and practicing attorney in Massachusetts for 34 years. And in recent times, after leaving the trial courts, has turned her attention to healthcare in a variety of ways, including authoring and publishing a book to teach patients and their caregivers how to make healthcare choices that protect life and plan for their future healthcare needs. Currently, Pat volunteers as a speaker with the main group that opposes this initiative, Massachusetts Against Doctor-Prescribed Suicide, No on 2. So welcome, Pat, and thank you very much for coming. And as everyone came in, you should have received, there's a very large packet in front of you that is the actual law in its entirety as written and to be voted on. And there was also a smaller handout, which is a summary of the salient points of the law, which I thought I would introduce before we get started. And then we'll progress into statements by the proponents and opponents of the law, and then we'll open the floor up for questions. So if you look at your summary, I'll just quickly go through it. This proposed law would allow a physician licensed in Massachusetts to prescribe medication at the terminally ill patient's request to end that patient's life. According to the law as written, the patient must be a Massachusetts resident, at least 18 years of age. The patient must be mentally capable of making and communicating healthcare decisions, must have been diagnosed with having an incurable, irreversible disease that will, within reasonable medical judgment, cause death within 6 months. The patient must also make the request for the prescription of medication at least twice, once verbally and once in written form, and in written form in the presence of 2 witnesses. Each request must be made at least 15 days apart. The physician, on the other hand, will be required, if this law passes, to determine if the patient is qualified, required to inform the patient of the diagnosis and prognosis, the potential risks and results of ingesting the medication, and of feasible alternatives, including comfort care, hospice, and pain control. The physician must refer the patient to a second consulting physician for a diagnosis and prognosis, confirmation that that patient is capable of making informed decisions, and refer the patient for a behavioral medicine consultation if the physician believes the patient has a disorder causing impaired judgment. The physician is not required, but is required to recommend that the patient notify next of kin, recommend that the patient have another person present when ingesting the medication, and inform the patient that he or she may rescind the request at any time. The physician then is required to write the prescription when all the requirements are met and arrange for the medicine to be dispensed directly to the patient. What will your vote do? A yes vote would enact the proposed law allowing physician licensed in Massachusetts to prescribe medication at the request of a terminally ill patient meeting certain conditions to end that person's life. A no vote would make no changes to existing laws. So, a couple of reminders first. Don't forget to vote next Tuesday, November 6th. It's certainly a critical question, and that's why we're all here tonight. After statements from our two distinguished panelists, we'll entertain questions from the audience. And what I ask is that only questions be asked as opposed to statements of position by the audience. We have our guests to make those statements, and they're here to answer our questions so we can be more fully informed voters. And also, if your view is different than one of our speakers, we urge you to resist the urge for verbal outbursts or anything that might be construed as a personal attack on our panelists, who have been very gracious to show up here tonight. And the program will last 1 hour. So thank you very much, and hopefully that's all that I'll have to say tonight. And with that, our proponent, Kevin Cousins.
Well, thanks for the introduction. Pat, it's great that you're here as well. I'm grateful for this opportunity to be having a dialogue with you about this really important issue of death with dignity. And I'm incredibly glad that it's both on the ballot and something that we get to talk about and decide next week. Really, it's very quick. The election's coming right up. Also want to say thank you all to all of you for coming out here amidst this terrible weather and this power outages, etc. So thanks for all for being here. This law, as Paul explained, allows for an individual who is making their own choice and their own decision to request life-ending medication when they have an illness that is going to end their life within 6 months or less, according to 2 doctors. In the last 1.5 years, I've been working in hospice. I'm currently a private practice psychotherapist, but I've had a lot of hospice experience, and both personal as well as being employed in hospice. I've had a lot of time working in that arena. And any time you're dealing with end-of-life issues, it's hard. In fact, most people don't want to talk about end-of-life issues at all. If we could avoid it, we would. We want to leave the room often. One of the first stages that people go through in terms of grief when they learn about a prognosis or a diagnosis of something terminal is denial. We don't want to deal with these issues. And yet, all of you showed up here today, which is quite remarkable, because this is something that is very important. And what's important about this is providing people with choice. The reason why I'm standing with you right now, the reason why I care about this issue as much as I do, is working with people who would have wanted to abuse this law but couldn't. People, it was my job to be with people at the end of their life, provide counseling for their families and for the people who are dying. In hospice, so I'm not sure how many people, raise your hand if you know what hospice is. And that's everybody. Okay, so for a person to have a hospice diagnosis, or excuse me, prognosis, a person needs to be certified with 2 physicians that they have 6 months or less to live. Well, most of you here probably know that that doesn't always pan out. Sometimes people live longer or shorter. In fact, oftentimes people are only on hospice for about a week, or the next 2 weeks. Most people aren't on it for very long. This particular law is providing for those people who would have that type of diagnosis and prognosis, so 6 months or less, and give them the choice of ending their own life. And what I want to emphasize is that there are a lot of protections around this law, a lot of protections around the individual, meaning that they have to ask once, then they have to wait 15 days, and then ask again for this. They also have to write and physically be able to handwrite to request the medication. A lot of people at end of life don't have the ability to hand out. If you have something like ALS or Lou Gehrig's disease, a lot of people at that stage, by the time they have 6 months or less to live, can't physically sign. This law doesn't even apply to them. It doesn't help them, unfortunately, because some people would want this. So for the people who are mentally able to request this, okay, so there's no what's called the healthcare proxy. Healthcare proxy is not in vote, meaning they're able to make their own decisions. They don't have a guardian who's making decisions for them, so this is their own will. They can then request this medication. And what this medication essentially is sleeping pills. It's barbiturates. And so people take this medication, and typically they fall asleep and don't wake up. No pain involved. This law has been in place, so the Massachusetts law is modeled after the Oregon and Washington laws, and those laws have been in place in Oregon for about 15 years and in Washington State 4 years. There's never been a reported case of abuse, ever. Last year, about 70 or so people, I think it was 71 in each state, requested, or not requested, used the medication. Someone, over 100 people actually received the medication, but a third of people who request it never use it. And not just request, I should say, a third of the people who are prescribed the medication, because a lot of people die before they can actually get the medication at all. It's about people who are already dying. The other piece about this, and this is a legal component, is that if a person dies, the death certificate states the terminal illness. So if a person is dying of cancer, it'll state cancer on the death certificate. And the reason for this is that, let's say you have a life insurance policy, you won't be penalized for this. And also, there's a certain stigma around the word suicide. And that's not what we're talking about. And that's why the law in Washington and Oregon, and the law that's being proposed here, does not use the word suicide on the death certificate, and thus the insurance companies are required to treat it as if the person died from the terminal illness that is already killing them, that they're already dying from. So that's a really important point. And I want to bring up the point about language, because as we all know, words are powerful and language is powerful. And the word suicide is very powerful. It's charged. I'm a social worker and I work in mental health. I fight against suicide truly on a daily basis. This is when a person is ending their own life in a way that I see as irrational and often caused by a debilitating condition. That's not what we're talking about here, okay? What we're talking about is, that's why I talk about it as physician-assisted dying or assisted dying, because the terminal illness is what's ending this person's life. They're choosing, if given this opportunity, the person would be choosing to hasten that death. Okay, that's why there's a big language difference, and that's why I don't use the word suicide. I talk about assisted dying. And people also call it physician-assisted dying or physician-assisted suicide. I call it assisted dying because, yes, the physician is making sure that, there are two physicians that are making sure that the person has the terminal illness. But my goodness, it's not the physician that's choosing to end the life of that person. The person's already dying and has a terminal illness. It's that individual who's requesting this 3 times and having to wait 15 days and having to sign something with witnesses. This is not about another person doing it to you. This is about giving that person choice. Most people I know of would not ever use this. But for the ones who do, those are the people who this law is for, and that's why I think that this should be a choice. The last thing I'll mention, because I'm sure a lot of things come out in questioning, in the questions that hopefully you will ask. One of the things I really love about this law is that physicians are required to bring up the 4 different options available to them. They're required to talk with their patients about prognosis and diagnosis. And they're required to talk about pain management, palliative care, hospice, and death with dignity. And what we've seen in Oregon and Washington is more people using hospice, more people knowing more about their end-of-life prognoses so that they are choosing and making conscious, rational choices around the end of their life. when I talk to my colleagues, hospice chaplains, social workers, music therapists, nurses, aides, I hear them voicing support from this. I've also heard different things from administrators, because there's a lot of fear around this too, and that's understandable. This is a scary thing. And to think that we would be harming another person, and that's not what we're talking about. We're talking about giving people choice. So, thanks for your time, and I look forward to your questions.
Thank you, Kevin. Okay.
Good evening, everyone, and thank you for allowing me to share some of your evening tonight to talk about this terribly important subject matter. We can all agree that all people deserve a dignified death. It's what we wish for ourselves, for our loved ones, even for those we don't know. The question is how to achieve it. And whatever your views of doctor-prescribed suicide might be, whether you're for it or against it, the fact is that the proposal that will be before voters next week as question 2 is simply not the way to go. It is, in my 34 years as a lawyer, I've read many, many statutes, federal and state, but I've never read anything as poorly written, as flawed, and as lacking in adequate safeguards as is in this 10-page proposal. And I'm going to give you a couple of examples of why the way it's written causes me great concern. First of all, just the criterion for eligibility to request this prescription. The patient must be diagnosed as having a terminal condition. The statute defines that as an irreversible and incurable condition which will cause death within 6 months. Now, language is important, as Mr. Cosens has stated. Keep in mind that this definition does not say that this disease is untreatable. The significance of that is that someone with a condition upon which they're dependent for medication or treatment to sustain their life, such as a diabetic who's dependent on insulin, can continue to take their insulin and have a relatively normal lifespan. However, if they discontinue that medication, chances are they will die within 6 months. That person would be eligible for this prescription as the statute is written. So it casts much wider the net of potential people who could be brought within the ambit of this proposal. The requirement that the death would occur within 6 months is itself elusive because doctors agree that this prognosis is often wrong. The groups that I've addressed, most people know someone who has had this type of diagnosis or prognosis and has lived far beyond that life expectancy. In fact, the records that we have from the Public Health Department in Oregon for 2011, which reports on the 3 prior years, indicate that the time from the patient's request for a prescription until their death varied from 15 to 1,009 days. That's almost 3 years. So you can see, just by virtue of this bit of evidence, how far off these prognoses can be. The significance of this is that someone who has been given a terminal diagnosis, I can only imagine how their state of mind will be affected by that diagnosis of perhaps fear, panic, hopelessness, who may be prompted to give up and prematurely request a prescription as a way of taking an easy way out, when in fact it will end up causing their deaths prematurely. A second criterion for eligibility to request this prescription is that the individual have to be an adult with the capacity to make a clear and informed decision about their medical care. However, there's no requirement for that patient to undergo any kind of mental health or psychiatric evaluation at the time of this initial request, despite the fact that study after study has shown that most incidents of suicidal ideation, suicidal thinking, stems from depression. Depression is a treatable condition. The need for intervention at that initial point to catch those people who could receive mental health therapy and have their lives saved is essential, but there's no requirement for that in this proposal. In fact, studies show that when people with depression are treated, they completely change their mind about wanting to pursue suicide. The second piece of having demonstrated that an adult has the capacity to make this decision must be also that they have the ability to communicate this decision. The proposal provides that communication may be performed by someone who will facilitate the communication for the patient. For example, if the patient doesn't speak English, you could have an interpreter come in and say, well, this is what the patient is saying. He or she wants to request this doctor-prescribed suicide prescription. Or a patient who communicates non-verbally, who may have a paralysis, but communicates with eye blinks. An individual could come in and say, well, great Aunt Maud here, I'm familiar with her manner of communicating, and I know that when she blinks 3 times, that means she's asking for this prescription. There's no requirement for that interpreter to demonstrate expertise, reliability, or disinterest in the outcome of this decision. In other words, that could be someone who will stand to gain from the death of this patient. There's no protection against chicanery by an individual in that regard as far as the patient's requesting this prescription to begin with. The requirement that the form be voluntary is important, and it is a good one to have. But the requirement for the written form for the patient, it completely undermines the voluntariness of this requirement. The form is part of the proposal that's written into the statute. It requires that it be signed by the patient in the presence of 2 witnesses. However, only one of those witnesses needs to be disinterested, meaning that person will not stand to benefit by the death of this patient and is not a relative related by blood, marriage, or adoption. The other witness may be an heir and related by blood, marriage, or adoption to the witness, to the patient making this request. The significance of this is that if you compare it to the situation in Massachusetts of someone who's executing a will, you must have 2 disinterested witnesses. 2 disinterested witnesses to attest to the fact that the person making the will is under no constraint, undue influence, is acting of sound mind. This gives us a heightened sense of reliability that what the witness is attesting to is true. There's nothing to gain by the witness lying because they're not going to inherit under the will. If question 2 becomes law in Massachusetts, it will result in a situation where you need 2 witnesses to dispose, disinterested witnesses to dispose of your property, but only 1 to dispose of your life. Ask yourselves, is that really an adequate protection? Now, I've mentioned 3 points about what is written and the way the proposal is written, but what it doesn't contain is equally important. And I think there's probably a common misconception out there that this is simply a process of taking a couple of sleeping pills, as Mr. Cozen characterizes them, and lying back peacefully on a pillow and slipping painlessly away. Nothing could be further from the truth. This is the dose of Seconal, the drug that's required for a person to end their life. These capsules are exemplar, they are not filled with the drug, but these are the exact capsules that would be dispensed. This is the actual dose of 100 pills that the patient has to ingest all at once. The contents of the pills have to be opened and dissolved in applesauce, pudding, or some kind of liquid in order for the patient to take them down quickly enough to cause the death. Side effects include seizures, vomiting, for which other prescription would be required from the doctor, and death can take 3 or more hours to take place. Despite the potential for these serious complications, and despite the fact that someone could ingest 3/4 of this stuff and decide, wait a minute, I don't want to do this, I don't want to do this, I've changed my mind, there's no requirement for a doctor to be present at the patient's bedside. This proposal completely abandons the patient at the most critical point, which is when they are taking their own lives. Not only is there no requirement for a doctor to be present, there's no requirement for a witness to be present. So you are inviting a situation where someone could be tricked into taking these, someone could be coerced, pressured into taking this drug against their will, and no one would ever know. The policy of this proposed law would be to facilitate intentionally ending a human life in secret. Ask yourselves, is that a safe policy for the welfare of the citizens of this Commonwealth. There is no provision in this law for enforcement or investigation of these deaths by the Commonwealth of Massachusetts. As Mr. Cousins pointed out, the death certificate will state that the cause of death was not suicide, it was the underlying disease. I suggest to you that the significance of this is that deaths by suicide are to be reported to the state medical examiner, the purpose for which is to conduct an investigation of that death. There's no death certificate that says suicide, no report to the medical examiner, no investigation. So these are just some of the inherent risks in the way this proposal is currently worded. But I want to say a brief word about choice. Just imagine a medical treatment is available to save your life, to extend your life for a period of time. But your health insurer denies you coverage for that treatment and opts instead to offer you the suicide pills. This is closer to reality than you might think. Cost containment in healthcare is a reality today. Just last August, the governor of Massachusetts signed the Healthcare Cost Containment Law. It seeks to cut $200 billion from healthcare costs over the next 15 years. Most of that will come from healthcare for those aged 65 and over. Question 2 allows insurers to steer patients to the suicide option. We can't rely on insurers to do the right thing versus the cheap thing. In fact, this has happened in Oregon, one of the only 2 states where doctor-prescribed suicide is currently legal. A woman by the name of Barbara Wagner, 64 years old, at 4th stage lung cancer. Her doctor prescribed a drug for her, Tarceva. It's $4,000 a month to acquire it. She was insured by the Oregon Public Health Insurer. They denied her coverage for the drug, but they said they would pay for the suicide pills. This created such a public relations nightmare that the manufacturer of the drug came forward, Genentech, and agreed to provide her the drug for free. Mrs. Wagner lived another 2.5 years. Doctor-prescribed suicide and financial pressure in healthcare is a deadly mix. There are many groups that oppose doctor-prescribed suicide. The disability rights groups oppose this. The American Medical Association opposes it. The Massachusetts Medical Society opposes it. Question 2, if not passed, will not take anything away from the rights of patients in Massachusetts today, who have for decades had the absolute right to control their health care, to accept or refuse treatment. This is not about patient rights. This bill is about providing immunity to doctors, which was the testimony of the current president of Compassion and Choice, the group that is sponsoring it. They're formerly known as the Hemlock Society. She testified before a U.S. House of Representatives committee in 1996 that that was the purpose of this bill, to provide immunity to doctors from liability. Given the potential for harm as this proposal is written, I ask that you consider whether this is wise, whether this is safe, and whether this is truly necessary, and that you vote no on question 2. Thank you.
Thank you, Coach. At this time, we'll entertain questions from the audience.
I have a question. You mentioned the number of reasons why people should not vote on question 2. How could this be written so that you would suggest that people should vote for it, or are you against this philosophy in general?
I'm only here to comment on the proposal as written. If someone wants to present to me another law, another proposal, I'll be happy to review that, because my personal views are really irrelevant. I'm really talking about what's before the voters and why I see the issues that create concern for voters and for the welfare of the state, citizens of the state, if this thing becomes law.
If I could, it's a similar question, but a little bit different twist to it. Who drafted the law, and did opponents, or was it wide enough participation that opponents could have influenced how it was written?
Can I stand for?
Yes.
And is that directed to me or Mr. Cousins?
Go ahead.
whoever, I don't know.
The
We'll
law is-
allow both speakers to come.
The law is virtually identical to the laws in effect in Washington and Oregon. It was, I don't know who drafted it, but it's virtually identical. The point being that for 14 years it's been in effect in Oregon. The drafters of it could have changed it over those 14 years. They could have tightened it up. They haven't changed it at all. It's the same law now in Massachusetts that they're trying to put forward. So you have to ask yourself, why did they write it this way? It must be because that's the way they want it.
I can actually, yeah, I'd like to add to that. I'm not sure about the specific legislation around the language. I can match that it's the same law, it's basically the same law, and everybody's pretty much in agreement that it's the law in Oregon for 15 years and Washington for 4. And the idea is that it's a pretty solid law. We're not seeing abuse, and it's well integrated within hospice. It's well integrated into those states and the legal system, et cetera. So we're not seeing the fear, and we're not seeing legal battles around this. No, it's pretty well, as far as the people in Washington, Oregon are concerned, this is well crafted. I know one of the proponents of the law is a woman named Heather Klisch, whose father was visiting Massachusetts, and so she's a Massachusetts resident who wound up getting headaches while he was here, going to MGH, finding out that he had advanced cancer, stage 4. He lived in Oregon, chose to go home, explored options, determined that he only had 6 months or less to live, wound up calling his family together, including Heather, who lives here in Massachusetts, and being at home with his family, putting on nice music, took the medication, mixed it with water, family sang together, wife got in bed with him, and he died peacefully. Within half an hour, fell asleep and died with his family in a safe, peaceful way. And that's why she is one of the proponents of this legislation, and that's why she wanted the language to be the same. So I can say that much.
Mrs. Babcock, and then you, sir.
You mentioned hospice
Yes.
as being a safe way to do this, but this is not just, unless I'm mistaken, for hospice. This is a law that covers everyone. Hospice, I can see, would be ideal that you did have people around you, but this is for the entire population.
Oh, yeah.
And yeah, go right ahead, and then if you would like to.
Yeah, absolutely. So this law pertains to everyone,
Yeah.
and doctors are required, the beauty of this is they're required to bring up the 4 different options. So pain management, palliative care, hospice, and death with dignity. And they can be in conjunction with one another. You can have palliative care, or you can have hospice and this when you're ready, when the person is ready. But it's always their choice. And the idea is that the government is not forcing anyone to do anything. That's why it's always about choice. So it's not only, the reason I bring up hospice so much is because it's the same prognosis as what's used in the standard of care by Medicare, a 6 months or less prognosis, which doctors have to choose at some point a line. And they get that pretty much right based on criteria. It's a statistical average.
I just make a point, bringing up options to the patient is not the same as making them available. All the statute says is that it recommends that doctors inform patients that there are such things as hospice and palliative care for them, and pain management. This, I read Ms. Klisch's synopsis is in the voter information book. And I think that's great that their family had this perfect fairy tale death for her dad. However, life is not perfect. My concern is for the other people who may be put at risk, whose lives are imperfect, who do not have family to support them, who do not have tender, loving caregivers, who have potentially relatives or heirs or family members who are looking to get this over with, who are burned out caregivers, or who just want to cash in on an inheritance, who are dependent, who are weak, who are vulnerable. There are many more of those kinds of situations, I'm afraid, all you have to do is walk into any nursing home today to see that people have been abandoned, and that this is an easy way to dispense with people whose lives are just too burdensome for others to put up with. That is my concern. And yes, it's not something that necessarily has to take place in a controlled environment like a hospice. In fact, this is a process of where it's like, here, the statute says, here, Miss Patient, here's your prescription, goodbye and good luck. The patient doesn't even have to make the request in the presence of the doctor. It could be made by a phone call. Hi, this is Pat. I have that, doctor, remember I got that terminal disease? Well, I think I want that prescription. I'll mail you the form. Goodbye. That would be sufficient under the statute. Is that really safe enough? Is that really controlled enough? The patient is abandoned at the most critical point when they die. They don't have to have anybody there to document their time of death, the manner of death, whether there are abuses. And as far as Oregon's saying there's no abuses, there are plenty of abuses that have been reported in newspapers in Oregon and other kinds of reports. The public health reports, as a matter of fact, are inherently unreliable because there's no requirement for doctors to file the reports. They're asked to file the reports. It's done on a goodwill basis, but there's no penalty if they don't report the circumstances of their patients' deaths, and that's the same circumstance as in Massachusetts when Duquesne. There's no requirement for the Department of Public Health is tasked to ask doctors to provide information about these deaths. But the Department of Public Health has no investigative authority and has no right to enforce a penalty against doctors who don't report. So we don't know how many abuses have occurred in Oregon. We don't know, we will not know how many occur in Massachusetts. So there's much more to this law that has to be thought about very carefully before it became part of the fabric of society in Massachusetts.
Thank you. 1 second, sir. Just as a follow-up to one of the statements that you made, Mr. Cousin, in your understanding, if this law is enacted as written, can you telephone in to your attending physician and mail in the form without visiting that physician directly?
I think that's possible, because when a person is dying, when they're sick, when they're in extreme pain, they're dying of cancer, and they're home, would you request that that person go all the way into the doctor's office, find parking, schlep themselves into a physician's office, wait to be there? That typically doesn't happen. Typically in an end-of-life scenario, most of the people at end of life with 6 months or less to live don't have the opportunity of transport in that same way. That's very difficult. And that's why there are these safeguards to help people, to really make sure that it happens. And they're required to make sure that it's requested twice, and that these doctors know, they have to know their patients. They have to know who they're talking about.
Can I make one more comment?
Here, well,
Oh, I'm sorry.
We'll come back
there's
to
quite
that.
a few things. Actually, they're incorrect.
When I came here this evening, I thought that the end of the life would be a series of pills. There would be 100 pills that would be prescribed, and you'd take one every day, and then eventually, after 100 pills, which is 3 months or so, you're gone. But when Patricia took this thing out here, this jar, and dumped them in a thing and said, well, you gotta take them all at once, that didn't sound, so which is it a prolonged thing, or is it you have to take them all at once?
No, a person should take them all at once when they do it. It would actually be ineffective to take them half and half. A person who has a terminal illness, they're dying. Okay, the illness is killing them. They have had to think through this decision, be in touch with their physician about the choice that they're going to make. They have 15 days between the first time they ask and the second time they ask to get this medication, to get the pills. They have to write something and sign off on it saying that it is their choice and they've chosen to do it. And if a physician thinks that there's a reason why they shouldn't, if there's a need for a psychiatric consult, the physician is required to do that. If they think that they're not in their own right mind to make their own healthcare decisions, goodness gracious, a physician has to, legally, get a psychiatric consult. But if they're making their own choices, their own right mind, they can get the pills to do it. And they would need the whole amount, but that's the idea, in order to take a dose that would end their life. And they only do it when they're ready. If they want to get the medication, fill it, and never use it, they don't have to. And, oh, yeah.
I just had one follow-up thing.
Absolutely.
So when does the rescind come into this? You know, you take the pills, you're gone. Right?
That's right. When you take when a person chooses to end their life in this way, that's their choice. They've had to think long and hard about it. It can't be something like you can get married in Vegas very quickly, right? You can't choose to end your own life very quickly. The 15 days is one sort of parameter. It could take longer depending on how long they decide to wait.
One question that I have concerning this issue is 100 pills, certainly it's a dramatic number of pills. Is it always the case for, and you're dealing with a wide population of many diseases, someone who's 6 months from death to 2 weeks from death, is it always the case that the patient is recommended that they take 100 pills? Or is that for some cases and not for others? And either one can answer
That is the dose. This is the exemplar prescription label, which states, take 100 capsules all at once. This was prepared by a doctor who is advocating against question 2. I just wanted to follow up on a point that Mr. Cousins made. For the telephone request, inherently problematic. Who's on the other end of the phone, number one? Is somebody making this request for the patient? If the patient is so debilitated, so stressed, so at the point of desperation that they can't get themselves to the doctor's office, are they really in a state of mind to make a clear judgment about this decision? And should they not then have some kind of psychiatric intervention? Records in Oregon show that in only 7% of the cases, in only 2% of cases, were patients referred for psychiatric evaluation from 2008 to 2011. How can that be when most cases of suicidal ideation stem from depression? You can see that if it's not required, it's not going to happen. Also, the fact that there's no requirement for, scratched on my notes here. The doctor who is the treating physician is not necessarily the doctor who writes the prescription. There's no requirement that the doctor who's treating this patient actually write the prescription as requested. That doctor may refuse because doctor's participation is voluntary. So now what you set up is a situation where the patients will doctor shop, or someone with the patient will doctor shop. And there have been reported cases in Oregon where patients have gone into doctors who have been treating them. The doctor has refused. One woman was with her daughter. She shopped to get to a third doctor. Finally, that doctor wrote the prescription for the patient. Sometime later, the patient died. There was a concern by the treating doctor that the daughter was influencing the patient and was exerting pressure on her. That's why he wouldn't write it. But there will always be somebody who will. So this is the kind of concern that we have to be aware of that can and does happen.
I really need to address that because the situation of abuse is one of the biggest factors, right? It's the fear that someone else will be coerced. If a physician is aware of that, that would have to be reported. That would definitely have to be reported. And the whole idea of this medication not being tracked, the Department of Health in Oregon and the Department of Health in Washington keep excellent records on this. They don't keep records as to how a person dies because that's private and in the company of their own home. The choice, unless it's in a facility like a nursing home or a hospital, the whole idea is that this is not something that's forced on anyone else. And if there's a thought of coercion, that's reported. It has to be reported. If any one of us here was going to harm someone, that has to be reported. If in the event of that happening, we thought that any one of us would withhold treatment from someone or somehow stop something, that's that's a real issue. We're talking about this fear. I mean, essentially what we're talking about is fear over what might perhaps happen to someone else. And what we've seen in Oregon and Washington over and over and over again is that fear is completely unfounded, and that this law is not abused. And it's really taking something we're intersecting between the legal and medical here. Legal, medical, and personal. There's this massive intersection. This is the law about something medical, but really something at the end of this is personal, very personal. And I think it passes the legal test. My colleague disagrees with me, Pat disagrees. But in Oregon and Washington, we've seen it pass the legal test of it being a safe enough and sound enough law to help to allow people this choice. Medically, doctors do not have to do this, and the point is doctors are given the option to opt out. If their religious convictions or personal convictions say that they couldn't do this, then that's fine, that's their choice. They have that option. That's why that provision is there. Doctors don't have to participate. Just like many doctors will not prescribe abortions. They won't, and that's their choice. A person would have to go to another provider. And then the personal. I may not agree with my uncle taking this medication. I might have a problem with it, but it's not my choice. It's his choice. It's about the individual's choice. So those are the three lines that are intersecting. It's about choice.
Am I misunderstanding you that you'd have to be at home to do this, that you couldn't do it in? I thought that was what you just said, that's why I'm asking.
Yes, I was describing it in the sense of one of the concerns that was brought up is that no one would be required to be present at time of death. Because it is such a personal decision, people can choose who they want to have in their lives and who they don't. Sometimes we have beautiful connections with our families, sometimes we don't, right? So the next of kin shouldn't be required to be there because our next of kin might not be someone who we want with us. So a person can use this where they want.
But if I were in a nursing home, then people around the nursing home would know that I had the prescription.
Absolutely, yeah.
And so there's kind of a consent on their part to,
Well,
assist with it. It's
right.
kind of, I don't know, it confuses me.
Sure, in a nursing home, one can, I mean, sometimes people remove, in a nursing home, people remove all sorts of things, like feeding tubes, right?
Yeah.
Which end a person's life, but we're legally right now, a person can choose to remove. They can withhold life-sustaining treatment. Okay, this is taking it another step. What this is doing is allowing a person to end their own life on their own. So in the same sense, people in nursing homes and hospitals already deal with this type of thing, except what's different is that it's about choice and choosing to do it on their own. Right now, some people, when they want to end their own lives, the only way they can do that is to stop eating and drinking, which is what a lot of ALS people with Lou Gehrig's disease choose to do. And unfortunately, I've witnessed here in this state, working in hospice in the towns right around here, and this gives people another option. No one wants to use this. No one wants to be in a situation where they have a terminal illness, where they think they're going to be in enough pain or are in enough pain to want to use this. But in the case that they are, for the very few people that this applies to, I think they should be given this choice.
Can I speak to that?
Let's go to the next question and then come back.
Does having a health care proxy for a parent have any bearing on whether the parent can or cannot do that? Or the relative, whatever?
Pat, do you want to answer that?
There's a real problem if this became law in Massachusetts, and that would be a conflict with existing law, which is the healthcare proxy statute. The healthcare proxy statute, for those who aren't familiar with it, is a provision which allows you to appoint someone to act as your healthcare agent in the event that you are unable to make or communicate healthcare decisions for yourself. You prepare a form that is called a healthcare proxy, and you appoint someone who would serve in that capacity if at such time you were determined to have not the capacity to make your own healthcare decisions. And the agent's authority is fully extensive with any kind of decision that you could make if you had the ability. Now, in that statute, there is a provision that limits the authority of the healthcare agent in one particular, and that is that they may not choose euthanasia, assisted mercy killing, or any means of death by other than natural means to cause the death of the patient. So there is a prohibition under the healthcare proxy statute. However, in question 2, there is a provision that says no agreement can limit the right of anybody to choose doctor-prescribed suicide. So now you've got these two proposals that are diametrically opposed. This sets up a situation in which a healthcare agent for a patient, an individual, could say, you know, I think that Muriel here would choose doctor-prescribed suicide given the circumstances, and I can make any decision she could make. And so I'm going to choose that. A family member could come in and say, wait a minute, I'm Muriel's sister, and I know she would never choose this. And under the healthcare proxy statute, you don't have the authority to make that choice for her. Boom, you're in court before a judge in an emergency session. It's going to be for the judge to decide which law is going to control that situation. I frankly don't know how they will decide that. Whether they will go with the healthcare proxy statute, which is a very comprehensive statutory scheme that's been in effect for over 20 years, or the more recently enacted doctor-prescribed suicide law, taking that as the more current version of the will of the people. So that is kind of an unknown and an issue that is to be determined at a later time. But one point I just wanted to make quickly.
Well, can we, I think that the healthcare proxy issue is clearly a very important issue. We all have healthcare proxies. And I know that the healthcare proxy law is designed for when you can't speak for yourself. But from my understanding of this law, it's this, to be an eligible patient, you must be able to communicate directly with the physician yourself.
The healthcare proxy statute
And then I want you to speak to that.
imbues the agent with the authority to speak for the patient, as though the patient, you can make any decision as a healthcare agent that the patient could make. So you've transferred to this agent now the capacity of the patient to choose. And I don't think it's at all clear that this statute would prohibit an agent from acting and choosing doctor-prescribed suicide. It even says that no agreement can limit the choice of a patient to choose this, a doctor-prescribed suicide option. So a healthcare agent would not be able to prohibit, or would not be able to avoid that choice.
I need to respond to this, because let me be very clear, extremely clear on this. Put me on the record, up in trial, whatever it is. A person needs to request this themselves. Everyone who has a healthcare proxy, which does mean that a person can make healthcare decisions for you when you're unable to do so yourself, they've had to have a physician. The attending physician needs to be the person to say that the healthcare proxy is invoked, which means that that person is no longer able to make their own decisions, that someone else has to make those decisions for them, right? Yes. Okay, if you don't have a healthcare proxy, please talk to someone and get one. Talk to me, I can help you get one. I can help find someone to help you get one. Because it's great to make those decisions in advance. Okay, those are decisions that you make in advance. This law is absolutely not that. It's something that you have to make yourself. No one can make this decision for you. No healthcare proxy, no person who you designate can ever make this decision for you. The only person who could make this decision is the terminally ill patient, and they have to make it 3 times. No one. And this law is very clear. This law in Oregon and Washington, really, when you take a look at this law, you'll see that no one can make the decision for the patient themselves.
Here's where I think that we're talking across purposes.
Mm-hmm.
No one can make the decision to make the request for the prescription but the patient. But let's talk about a patient who is competent to make that request for the prescription, and who later, her competency is impaired and now has a healthcare agent deciding to enact the act of doctor-prescribed suicide for the patient, who now has lost competency. There's no requirement at the time of death that the patient be competent. There's two separate areas here of where you've got to decide about the patient and their ability to decide. And in the second case, where it's now, we're going to give the patient these pills, that the healthcare agent could act for the patient.
No one can force, no one can, and this is, I hope you don't get too much into this. You want to ask questions about healthcare agents after. No one can force another person to ever take this medication. This medication has to be taken themselves. So as a person goes along in their illness, if they're not able to competently make this choice for themselves, they can't get the prescription, open it, mix it with however they're going to prepare it, applesauce, water, whatever, themselves. They have to make this of their own volition. If this is done to another person, okay, that's illegal. That's not allowed. So this is, again, this is always about choice.
Do we have another question?
Well, just carry this a little further, and I'm sorry, I don't mean to dwell on it, but I think that you can lead people to make decisions, especially the elderly, and that bothers me. You know, I have a healthcare proxy for my mother, and I know that I could say, Mom, this is a good decision for you, and you could just take this, and she would do it. She doesn't have the cognitive thought processes anymore to deal with this. So who stops that?
No one. That's just it. There's no safeguard to prevent abuse. You have the right mind to understand that you're dealing with someone who's very dependent, who's very vulnerable. There are a lot of people who would take advantage of those situations. I'm sure you've all heard of situations where adult children or caregivers have taken terrible advantage, financial, psychological, what have you, of elders. Elder abuse increased 31% in Massachusetts from 2008 to 2011, and most cases are unreported. Most cases occur in homes. This is a real serious matter, and this law, this proposal, if it became law, is a recipe for elder abuse. It's setting the stage for people who do not have honorable intentions to take terrible advantage of the most vulnerable in society. And where Mr. Cousins keeps talking about this being a choice, I suggest to you that there are many instances in society where we decide that the choices of the few may need to be limited in order to protect the welfare of the many. It's why we have non-smoking laws that would restrict the rights of smokers. It's why we have leash laws for dog owners to restrict them in how they take care of their pets. This is just another incident where we would, if we voted against this, we would be limiting the rights of those who feel they need the approval of society to commit suicide. You can say this is death with dignity, you can call it a humane and dignified ending. This is suicide. Yes, it's a terribly scary term. This is a reality, this is a scary thing we're talking about. And in fact, the ethical standards of Mr. Cousins' profession, the National Association of Social Workers, agrees with this concept of limiting certain rights of self-determination, which they state.
For the essence of time, we're dealing with one specific issue.
We're talking about choice.
Right.
He keeps bringing it up.
Well, the question was, how do you safeguard our healthcare proxy from influencing an elder? And you did address it, and I think you should have a chance to address as well.
Yeah,
I'm trying to get in as many questions as possible.
I'm trying to keep, hopefully my answers are to the questions directly. I know it's very easy to speak about many things, answer a question and then keep going on for a while, and I'd love to do that, but we're very short on time. Healthcare proxies get invoked, okay, when a physician feels like a person is no longer able to make their own decisions. In this case, there are two physicians who are certifying that the person has a prognosis of 6 months or less to live. And really, the person hopefully would catch that. So you're using a situation that you would have the ability to manipulate your mother into a decision. And hopefully the physician would pick up on the fact that this person doesn't have their ability to make their own decisions. They're not requesting it themselves, they're being influenced unduly by someone else. And this is something where they would have to catch if there's coercion or not. And I tell you, in hospice, the reason I bring this up is because it's important. We've seen this law take place in Oregon and Washington. And I've been on the phone with people who are working, and I use hospice because that's my example. I worked in hospice, end-of-life care. And I've talked to social workers, I've talked to nurses, I've talked to chaplains. They have not seen abuse in this way. It's all been about people making their choices to end their life.
Another question from the audience?
Both of you spoke about the necessity or the lack of necessity for any psychiatric evaluation. I'm unclear what section 6 means, counseling referral, and it says in the opinion of the attending physician, blah, 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 a patient may be suffering from a psychiatric or psychological disorder or depression, then that person shall ask for consultation. So shall means that, to me, that the physician has to ask. Am I reading it?
No, you're reading it correctly. The physician, if they see, and this, there's a real distinction. So I'm a social worker. I do mental health. I'm a therapist myself. If we see certain symptoms of depression, which are clinical symptoms, if the physician sees that, they would required to make a psychiatric consult. And that the way the law is stated, and there's a lot of stipulations across 10 pages, it explains that it's either a psychiatrist or a psychologist. Okay, and they're required to have that consult. Okay, that's within the law as it is. If a person is experiencing sadness and feeling depressed, there's a big difference between a clinical depression, which can cause suicidality, and feeling depressed about dying. My goodness, these people are dying. Of course, they're going to feel depressed. They're going to feel sadness. But that word has two different meanings, or a couple different meanings. And one is a clinical depression where they meet the symptoms of a clinical depression which can cause suicidal thinking. And that's not what we're talking about here. Okay, if they have something like that, they are required to have a psychiatric consult. Yeah, there's that safety and protection.
Section 6 states that all the attending and consulting physician have to determine is if the patient is suffering from a psychiatric, psychological disorder, or depression causing impaired judgment. That's when they have to refer them for a psychiatric consultation. However, the treating physician and the consulting physician's expertise is not in mental health disorders, it is in the underlying illness. So and evidence of the fact that these consults are rarely made is the fact that in Oregon, only 2% of patients were referred from 2008 to 2011. 2% of patients, 98% of the people who came in and asked for these prescriptions were not referred for psychiatric evaluation. How can that be when most of the time suicidal ideation stems from depression? And it shows that if it's not required for psychiatric evaluation to intervene to pick up these people who could benefit from mental health treatment rather than prescription to end their life, it's not happening if it's not required by the law. This law doesn't require it.
Another question? Sir?
I've got a question about pills. Now, I'm a person, I take 3 pills every day. One is prescribed, the other 2 are voluntary because I'm participating in a study. It's a pain in the neck every day to remember to take those 2 pills. I couldn't even imagine taking 100. I look at the flip side of this. I look at this whole issue as not just end of life, but quality of life. And the reason I want to do this is because quality of life is diminished to a point where, I'm in such pain that it's not worth going on. On the other hand, I tell my kids, who I assume will outlive me, if I'm told I got 6 months to live and you find some way to keep me alive for 3 years, I'm going to haunt you for the rest of your lives. So, I mean, there's a lot of issues here. But the pills, the number of pills really bothers me. Why can't you just take a shot?
Why don't we let Pat start and then you respond?
There is a prescription you can take for Nembutal, which is a liquid. I don't know the quantity, but that's $1,000. The pills are $125. You have to take, not the pills, you take the contents of the pills, dissolved in applesauce, pudding, or a liquid, and take that down very quickly. Gentleman in Oregon took them too slowly, fell asleep for 65 hours, woke up, decided he didn't want to die after all. So you have to take them rapidly, and then again, deal with any side effects that may occur.
The reason why it wouldn't be done to you is, I think, another one of the safeguards that's built into this legislation. It's death by lethal ingestion. Okay, you are choosing to take the medication yourself. And unlike your 3 pills, these pills, dissolve them and drink them.
And then take them apart to dissolve.
I think, I don't know enough, but I'm pretty sure that, from what I understand, you have to take them apart.
Yes. It's not advertised, it's shown on TV how you do it.
You know, there's a lot of, unfortunately, there's a lot of fear mongering on TV, so I don't
So
necessarily
show
buy
them,
that.
you know, opening them up, you have to put it,
Right.
yeah.
There's a lot of fear mongering on TV, and there's millions, literally millions of out-of-state dollars being spent on marketing and television ads that are against this legislation. And in fact, you find more volunteers on my side and a lot of political money, out-of-state political money in the opposition.
Sir, Ron.
There's no political money on my side, we're scraping to get by, you know, we couldn't even buy yard signs. So it's a lot of people giving their time freely and voluntarily. I wish we had some political force, but we don't.
But the only ads that I've seen are against the proposal.
Oh, no, I've seen one in favor.
You have?
Yeah.
I mean,
Yeah,
I've been, since I was asked to be the moderator of this debate, I monitored, whenever I watched TV, I kept a record, and I only saw ads against the proposal. So they must be, you must have a marketing budget that you're dealing with.
Well, it's not just my organization, it's my group that's doing it.
Right.
But I point out, when you talk about fear mongering, there's nothing excessive or hyperbolic in any of those ads or in anything I've said today. The reality is scary. The reality causes fear because when you don't speak in euphemisms, as this proposal does, you don't lull people into a false sense of security, as this proposal does. You have to deal with the reality of what life is like and what it will be like if this becomes law. I'd like to say that in terms of the example that Mr. Cousins used of people having a choice and using this being self-administered, an ALS patient couldn't begin to self-administer this because they haven't got the physical dexterity or muscular control to do this. And there are many people who would fall into that same category. So you're now talking about who's helping.
Can I respond to this question?
Yes,
That
absolutely.
the answer is, a lot of the religious groups that are against abortion are also the ones who are supplying money here, because it's a lot of evangelical groups that are pretty staunchly against any kind of ending a person's life in that way. So we'd be against abortion, we'd be against this as well. And as I mentioned, ALS, there are people who would want this law who can't use it. If you're paralyzed, you don't get to ingest this yourself. You don't get this choice. This choice is not for you. Whether that's good or bad, it's not an option for those people. It's only for people who have rational thinking who can ingest it themselves.
Ma'am?
Another statistic that came out tonight, I don't know if it's right or wrong, they mentioned on the news, 550 people in Oregon have availed themselves of this. And if it's for 15 years, 500, that seems like a very small amount.
If you took that percentage of people in Oregon who use this and applied it as a percentage of population, it would be 1,011 people in Massachusetts.
Over 15
Over
years.
14 years.
Is that statistics bear out as well?
596 people in Oregon over the first 14 years this has been enacted. As a percentage of 3.8 million people of the population, there's 6.5 million people in Massachusetts.
Okay.
So as a percentage of population, it's almost double.
We're talking about a small group of people. That's what you're asking about? It's
No,
true.
it's just something I.
Yeah, no, it's just a random number you saw on TV. Yeah, it's a really small, what I find interesting about this is that this isn't about a large group of people. This is often about a small group, but it actually does something great. And I was recently speaking at a church with a physician who was taking the opposite position. And the thing that we agreed on, which was great, is that this whole conversation is increasing knowledge about hospice, palliative care, pain management. It's helping people think through end-of-life decisions, so if you don't have a healthcare proxy, please get one. And then what this law does is it requires the physicians to talk about these very difficult issues. Instead of always pursuing, more radiation, more chemo, at least give the patient choice in what their healthcare decisions are, and they get to choose.
Sir, you had a follow-up.
Yes, it seems like doctors have so many constraints on them now on being able to interface with their patients. And so how about my doctor? Is he going to have additional training, or is he going to have to sign things, or what's he going to have to do to be able to prescribe this situation?
There's no provision in the proposal for any additional training or expertise of the doctor to prescribe this. It's just another drug that if it's available, and pharmacists are going to have to fill it. If it's a prescription that's put before them and they can get the drug, they have to fill the prescription. They don't have any options. The doctor's participation is voluntary.
The physicians, all physicians who come into this state and all physicians in this state are required to have training, specific training on end-of-life care. I wish all states had that, but in Massachusetts, that's very specific. So all physicians have a certain level of competency with end-of-life care. And so this would be something that all physicians would need to get themselves educated on. Most physicians that I know are certainly already educated on this issue because it's something that they're aware of. I mean, it's in the news. We're voting on it. It's coming up. And physicians have new things all the time that they have to stay current in. But in Massachusetts, all doctors are required to get special training on end-of-life care and keep that up with continuing education.
Anyone else? Great. First, I'd like to thank the audience for wonderful questions and for the heartfelt questions that you brought to our panelists. And just as importantly, I'd like to thank both panelists who clearly are passionate about this issue and have presented their cases remarkably well. I hope we can all leave here tonight more informed and a better electorate when we vote next Tuesday on this issue and all the others. So thank you very much.